Thank you so much, Kay, and to the whole panel. I lost track of time there because I was just so engaged in the panel discussion. In particular, the Aura Ring. I need to get one of those. Currently, my husband wears that instead of the wedding ring. So I don't want to waste any time. I'll go to the next panel, chaired by Dame Leslie Regan. The only thing I'd ask is, if we can keep some time. Yes, please, Dame Leslie Regan. The only thing I'd ask this time to the panel is if we can leave a few minutes at the end for questions. We really want to make this event as interactive as possible and as physical. As a GP, I want you to move your body. So when you have a question, please stand up. Let us know by putting your hand up, and we'll run over and give you a mic. Yeah? So... Yes. Yeah, Leslie, if we could just keep some minutes for the questions at the end, I think. My first view. Okay. Yeah.
So, you said...
Checking the batteries. Yep, you're good. They're automatic, so you just have to talk. Yeah.
Okay, so ladies and gentlemen, shall we start? Yes? So I'm going to introduce you to our panel. My name's Leslie Regan. I'm a gynecologist and part-time obstetrician, I suppose, at Imperial College, and I'm the Women's Health Ambassador for England presently. And to my left, your right, I have Dr. Sue Mann, who is my partner in crime and who is the first ever National Clinical Director at NHS England for Women's Health. Please note, not maternity, women's health. So she's a one-off, and she started on April the 1st, so best April Fool that we've had in 2024. Next to her is Professor Hilary Critchley, who is an expert in menstrual disorders and menstrual function, and who has a stellar career as a researcher in women's health. And to her left, and your right, is Dr. Shira Chok, who is the medical director at Tower Hamlets, and medical director, tell me. And tells me just a few moments ago, to my deep embarrassment, that she was a medical student with me, but that must have been a couple of weeks ago. So she's now in this position of great leadership, and what we thought we would do today is talk to this audience and ask you for help, because all of us have become progressively frustrated with how difficult it is to get women the sort of access and advice they need. So education, really good information, and then access to maintenance services. And I'm going to frame this talk in one slide, which if you could put it up for me, I'd be most grateful. And those of you in the audience who've seen me talk about this before, what is so extraordinary about the problems that we're facing in women's health at the moment? I heard, as I had a preview of the audience earlier, Kate Lancaster talking about a report that came out from the RCOG just 2 weeks ago, in which 750,000 women are on secondary care waiting lists for gynecological procedures, not cancers, and I'm not going to call it benign gynecology, I'm going to call it chronic disabling gynecological problems. So they have been deprioritized. And if we look, and I'm going to move on to what Sue Mann and I have been doing. In fact, it's ruined our lives for the last 3 months. She and I have been looking at the 600,000 women in England who are on gynecological waiting lists. And if I tell you that of those 600,000 women, our report is going to show that 87% of them will not need a hospital admission, and they will not need an intrusive procedure. So we have to ask ourselves, why are they on this waiting list? Why are they not being dealt with in primary care? Or do we need to create intermediate care for them because they don't need to go to secondary care. They don't need to come and see me in St Mary's Hospital, Paddington, for these various issues. So what we're going to do now is ask you to just remember this life course. If you're a female, there is an inevitability, the vast majority anyway, will menstruate. I personally don't know anything that happens to human beings more regularly than 12 periods a year for 40 years of their lives. For many of those 40 years, they're going to need contraception, and I hope that you would join with me in hoping that my daughters, I have twin daughters who are 32, in fact tomorrow, and I want them to be in a position where they can choose if and when and with whom and how many times they become pregnant. And then I also want to remind you all that although historically our politicians and our policymakers have viewed women as pregnancies or maternities, as you will see from that slide, only 4 out of 5 women in this country currently will become mothers. Some because they're not able to be, some because they've chosen not to be. So that's not an inevitability. And just to talk a little bit against myself, that little bit at the bottom, assisted conception and recurrent miscarriage, which I spent 20-something years of my life very involved in, look at how small it is in part of a woman's life course. And then we're going to move on to the menopause, because if you are a menstruating person, please note my politically correct language, there is an inevitability that you will become menopausal, some women earlier than others. So I just want us to think about that. These are all predictable. So why is it that women are waiting on these gynecological waiting lists? So I'm going to now pass over to Hilary Critchley, who's going to deal with menstrual health. And we're going to, at the end, ask you, because we're not going to speak for very long, we're going to ask you, with your clever AI and tech hats on, how we're going to crack these problems, because it's very evident to me that we haven't cracked them so far. Now, there, I think we're going to really be greatly helped by Shira Chok, because she was one of the individuals who worked at NHS Digital during the pandemic and suddenly made everybody in this room have a COVID passport on their mobile phone. Personally, I don't ever remember having given my number to anybody, but it all arrived on my phone. So I just think I'm using that as an exemplar that when we need to do something at pace, we can do it. So I would suggest to you that what we have to do in this room in the next 40 minutes now, because I've used about 5, is to talk about how we're going to do this at pace. So, Hilary, over to you for menstrual health.
So, can people hear me? Yeah. So, welcome everybody. Great to be part of this panel for Giant. And Leslie, I think your introduction was really important, because what it allows to highlight is now one of those time points on the life course. And we know that in a population of women, wherever you are in the world, 1 in 3 at least, and possibly more, will have the symptom of heavy menstrual bleeding. And the problem we have in healthcare delivery is that heavy menstrual bleeding, or abnormal uterine bleeding, which captures heavy menstrual bleeding, is a symptom. It is not a diagnosis. And if you have an event that can be coded, then we're able to capture those events when those who need healthcare seek help. So immediately we have a group of symptom sufferers who attend healthcare, but we have no way of really capturing what that burden is to the individual or society or wider. So in an outpatient setting, whether it's in primary care or perhaps this idea of intermediate care or even secondary care, we capture the fact the individual has attended, but what we don't do is capture what the diagnosis was for that woman. So those of you who work in AI, work in machine learning, we need your help to understand how we can better capture those events. The other thing is that those who attend for care don't just come for a single appointment. We've already heard these aren't conditions that are just managed as a one-stop, one event. If we went back half a century ago or more, everybody who had a menstrual problem had their uterus removed. end of story. Now, for various societal individual choice reasons, fertility desires, women don't want their uterus removed unless they've really come to the end of all their options or their end of family planning. And so we need to be able to have follow-up appointments, and the systems aren't designed to allow that. If you have a follow-up appointment, you may just go into a pool of other appointments, and you're not strategically getting that further follow-up, that further healthcare interaction to see if you're responding to that treatment option. So we need better systems, not only to capture what's the diagnosis, but how do we follow up. And in this sort of stepwise approach, as we move through that life course, that woman with her heavy bleeding may need to see other specialists. Maybe she's got a parallel heart or chest disorder. Maybe the cause of her bleeding is because of an inherited hematological condition. Or maybe she has decided to be amongst those 4 in 5 and have a pregnancy. And so we have wonderful opportunities at pinch points across that life course to actually connect better with the other aspects of healthcare access that person who presented, that woman with her heavy bleeding, in the clinic. And we're just working in silos. We're not joined up. And the final point is that we have huge health disparities, and those that suffer the symptoms most are those that are hardest to reach. We know that one of the commonest causes of heavy bleeding is uterine fibroids. It affects 80% of black women, 70% of white women, black women earlier, and therefore we have groups where we know it is harder to reach, and if we do research and we look at the demographics of so many research studies, they are very polarized and don't have the diversity that we need. And so I think that if I was giving you who work in AI, in tech, a challenge, it's how do we join this up? How do we capture the information that we need to try and improve our health services and therefore the care to those who access our services? So, thank you.
Okay, thank you. So I've already used up quite a bit of my time, so I'll be very brief. I'm just going to remind everybody in the room that contraception is the single most cost-effective intervention in the whole of healthcare. And if we had a whole load of interventional cardiologists here, they would have to agree that pound for buck or buck for pound or whatever, it is the single most cost-effective intervention. So this is not just about preventing pregnancies. This is about the importance of spacing pregnancies, because if you space a pregnancy by 18 to 24 months, every maternity complication is reduced. In particular, those ones that are particularly traumatic and very expensive to deal with. So one of the very few things that we can predict, for example, about premature births, is that if you have short interbirth intervals, your prematurity rate will increase. So will many other complications of pregnancy for that woman. And those are babies that are born early, are often the ones that are most damaged, and then have all sorts of problems in later life. I should also mention to you that obstetric litigation is actually costing us more than what we pay to deliver maternity services for the 750,000 maternities there will be in this country this year, or shall we say in 2025. So it's a really important point. And whatever your personal views are about abortion, we currently have the highest abortion rate ever since we started collecting records in 1968. The Act came through in 67, and the first records were started to be collated in 1968. And these are not young women. These are middle-aged women who, when we talk to them about why in their early 40s they're requesting an abortion, they will say they have been waiting for 18 months to access some form of long-acting reversible contraception, which additionally helps Hillary's patch. So many of the long-acting reversible contraceptive methods are also first-line treatments for managing disabling, heavy, painful bleeding. So I'm trying to give you a for instance about why is it that contraception has become so difficult to access, because it really has. And I'm not just saying, say my own London teaching hospital, but any of you who've been trying to access contraception as an individual will have found it difficult because the commissioning has become very siloed. And if you're not commissioning something whereby you also have to pay when you don't do it right or you don't do it well, there isn't an awful lot of incentive to do it well. So I think that's a really important point that we have to think about, because as we've heard, you're going to have all these periods, usually signifies that your fertility is now feasible, and women are not going to spend, well, there are very few women in this room today who will spend more than 2 or possibly 3 years of their lives pregnant. So since my actuarial lifespan is 80-something, and my daughter's, I mentioned, it's 100, we're going to spend an awful long time trying to prevent those sorts of problems. And then I'm going to pass over to Sue now, who's going to talk about the menopause, because as I was saying earlier, if you're a menstruating person, there's an inevitability that you're going to be menopausal. And then we're going to come over to Shira, who's going to give us some for instances about the enormously burden that disadvantaged groups of women have. So the worst catered for contraceptive-wise are women who are in marginalised groups. So we've got to think about AI solutions. They're going to provide really good information for girls and for women, not stuff saying on TikTok, oh, hormones are bad for you, but actually really valuable information that's actually correct. And we then need to find clever ways to allow them to access what they need so that they only get pregnant when they absolutely want to. Sue, over to you.
Thanks, Leslie. And I'm just going to pick up on the theme of scale, which I think is what we're talking about. And we're not talking about illness here. We're talking about the common things that all women manage. And, you know, in health, we're very, very used to talking about 1 in so many women or so many people can get this disease or that disease. When we're talking about menopause, we're talking about 1 in 1 women. So that's everybody who has periods. They are going to stop, and women will go through the menopause, often towards the end of their reproductive life, but not the end of their life. So often this is halfway point. So it's really important that we get this right in the way that information is all. So we know that women who have good information before they go through the menopause actually manage that transition better. So that's the place at which it starts. And I think actually there's an awful lot of tech out there in terms of helping women to get some of the things they need. But I think it's really hard to navigate, because I think some of it is really good and some of it is less good. And so it's trying to work out what is the information that we know to be true and what are the other things that might be helpful and might not. And so I think that it's very, very difficult. That navigational piece is very variable, and I think it's important because, as I said to start with, it's not a disease, but some people need help. And so it is also useful for women to be able to work out, do I need help or do I just need information? Do I just need to draw on the things around me? Sometimes that's just from peers or from local things, or sometimes it's medical. And medical support does have a place, but probably about 1/3 of women will sail through their menopause with very little in the way of symptoms, and then there'll be a middle group who will find it hard-ish, but okay, and manage, and then another group who will be really, really debilitated. And we need to find ways of getting the right help to the right people and helping women and the health system to navigate that piece. So how do people get into the health system? How do they know when to get help? How do they know their symptoms are related to the menopause? And not everybody does. Certainly there are a lot of, for example, there are a lot of cultural variations in how people perceive their menopause. So some cultures don't have a word for menopause. Some see it as a sort of valuable time, some see it as less so. So navigating difference and then helping the system to pick up on symptoms that may or may not be related. So when we move on to thinking about, well, probably all of you, if you have a healthcare problem, your GP is probably your first port of call, absolutely rightly. And GPs have such a wealth of information to know about and to be expert in, and we're asking more and more of them. Sometimes people present with very, very non-specific symptoms. So they might have some physical symptoms like hot flushes, but they might also have some mental health type symptoms. So you can imagine that there's a lot of overlap with all sorts of different conditions. And sometimes we need to help flag that actually is this menopause. So how do we help that conversation to happen effectively in the GP surgery so that both the person who's sitting there and the GP can get the best support for that person. And then obviously, moving on to, who are the people who need specialist care and how do we get them? And Leslie mentioned about the waiting list. There are very few people who do need specialist care in the menopause because usually it's not it's very specialist in terms of the experience people have, and it's very individual, but often it's not complex medically. But there are some groups where it's a bit more complex. For example, after women have had breast cancer, it's a very complicated thing to navigate how to manage symptoms. That's just one example. So those are a group of people who might need something a little bit specialist. So we're trying to design a system that speaks to all those levels and makes sure that we can support 51% of people going through that transition, but making sure that people get the right level of care that they need. And then the last thing I wanted to say was really about how do we support the healthcare professionals to do well for women. So what could we do through AI, through other techniques to ensure that the information that GPs and other healthcare practitioners, because it's not just GPs, it's practice nurses, it's the wider system, pharmacists, have that information to hand so that they can then be as supportive as they possibly can. So I think that there is so much that we can do with tech to try and shortcut those things, because it is really difficult for a health system to deal with half the population who are all going through a really, really important transition. So that's why I really welcome events like this, where I think that we can put our heads together and really try and come up with some good solutions and get things a little bit better. Thank you.
Lovely, thank you, Sue. So I've given you 3 pinch points, if you like: menstrual health, contraception, and the menopause. And remember that I'm probably one of the first generations of women who's going to be post-reproductive as long as she was reproductive, and that wasn't the case for my mother or my grandmother. Now, the biggest challenge I think we would all look to Shira to help us with is how are we going to make digitalizing and improving access to these common problems inclusive? How are we going to avoid leaving all those, we've banned the term hard to reach women. They're not hard to reach, but they're very, very easy to ignore. And my biggest fear about AI and our digital revolution is not that I don't fully understand it myself, but that we're going to make those marginalized women even more easy to ignore. Shira, over to you.
Thank you, Leslie. No pressure then. My name's Shira Chalk, and I'm a GP in Tower Hamlets in East London, just across the road from Sue. I was also the medical director for NHS Digital, and I started and lead a network for women in technology, in health and care, who are from BAME backgrounds. So that's the Shiri Network. And I don't know if there are any Shiri Network members here, but if you are, please do give me a wave, because it's lovely to meet you. Hello. So I learned so much when I was at St. Mary's Hospital under Leslie, and I'm still learning from her just a few years later today. So it's been such a privilege, Leslie, to have met you again. So I think what I'll do is structure my talk in 2 things. One is reflecting on my experience as a GP in a very diverse population in East London, and also the pace of change of digital transformation that we had to implement across the country during the pandemic. I was the Deputy Chief Medical Officer and then the Acting Chief Medical Officer, leading on the clinical governance of programs like the NHS app, the COVID Pass, the NHS website. If you booked your vaccinations online for COVID, that was our team of clinical informatics experts who made sure that that was safe. So that was a highly intense episode, but hugely rewarding in terms of the impact and the outcomes that we had. So first of all, the best thing about being in the Shuri network is I can draw on the expertise of the people in the network. So when I was preparing for this talk, I thought a little bit about maternity care and the inequalities that exist between maternity. For example, we know that black women, the risk of mortality is 3 to 4 times higher than in white populations. For Asian women, it's about twice as high compared to white populations. And if you come from a deprived population, again, your risk of mortality as a mother or somebody pregnant is twice as high. That's completely unacceptable. So I asked a digital midwife at Barts Health. I asked a chief nursing information officer in North London. And I also asked the National Chief Midwifery Information Officer for England, Jules Gudgeon, for their advice. What are we doing using technology? How are we using digital tools to improve access and to improve outcomes, and also to improve productivity and efficiency across the system, but putting patients front and center? And I'll just share maybe 1 or 2 examples, because we want to hear from you, actually, about what's happening within your organizations. So as a GP in East London, it can be sometimes difficult to communicate with some groups of women because English is not their first language. I speak Malay, which is not very widely used. I'm not very good at Arabic or French or German or Spanish. And it's really important when you're managing patients, male or female, but particularly when they're pregnant, to build that relationship and trust. And communication is so important. For people who are not used to the NHS, who are not used to the system within this country, it is bewildering. So how do you look after and provide that holistic care to people whom English is not their first language, there's a language barrier, there are cultural sensitivity issues as well. So really pleased that in North East London we are using a new tool, we're trialing that in maternity called Card Medic. And it may be something that some of you have heard of. It's an app that provides real-time translation for all specialties, particularly the top questions you're likely to ask in maternity or endometriosis or dermatology or rheumatology or mental health. And that can be used on your phone, on your laptop, on a pad, sort of iPad, or on a desktop. And the feedback so far, although it's early days, is that it is making a huge difference to building that communication and trust, because patient compliance with the plan, patient engagement with developing your care plan, particularly when you're pregnant or when you have women's health issues like endometriosis or menopause, that is so important. User engagement is absolutely critical. So the other good example I want to share is when I was at Barts Health, I was the director of primary care, trying to improve communication between a very big acute trust and primary care and CCGs at the time. We talked about silos early on, and electronic records or paper records, it's siloed. It doesn't help patients who have to explain the problem and explain the past history 3 or 4 times. It takes them a lot of time. So there was a lot of work done maybe about 8 or 9 years ago to share records, to share things like the past medical history, your allergies, your drug history in a secure way, which improves safety. It improves patient experience because you're not trying to explain yourself. As a patient, it gets really tiring trying to explain the same thing 3 times. And it improves productivity and efficiency. So we implemented that at Barts Health, working very closely with our commissioners and also with our primary care colleagues. And that makes such a big difference. So if somebody arrives in ED, emergency, for example, and they may be confused or unconscious, you're no longer working blind. You can actually, in many cases, look up the patient's record. So I'm going to very quickly talk about my experience in NHS Digital if I've got 2 minutes. I joined it in 2021 at the peak of the second lockdown. And what was the secret to implementing things at scale, at pace, and on time? One, obviously, it was a huge public health need. It was an emergency. There was a crisis. So it pulled people together across the systems. People were working collaboratively in a way that we had not done before. Secondly, at NHS Digital, I led a team of 100 clinical informatics experts. And the strength of our team is the diversity of our team. 45% of our team were women, so they had an insight into the challenges that perhaps women had. And we had people from midwifery, from nursing, from paramedics, from doctors, from pharmacy, very diverse in terms of profession. So we had that diversity of thought, and that fed into our product development. Things, as I mentioned, like the app, the COVID Pass, the NHS website, the vaccinations booking system. So I'll pause there because I'll hand back to Leslie for the Q&A.
Well, that's a really important point, isn't it? The diversity. And as I hope that we've been emphasizing today, there's so much more about women's health. I'm just going to get out here so I can see everybody who may want to ask questions. There's so much more to what we could be doing. And I just want to come back to my starting point again, which is, why is it that we've got 600,000 women sitting on a waiting list, and the vast majority of them, 85% of them, are not going to require a hospital admission? And we have to conclude that we have not gone about this the right way. So I would like now for us to think about and ask you in the audience to help us to design a system that's going to recognize that fact that these are not life-threatening problems, but they are life-disabling ones, and also bring us back to the finance of all this, because much as I don't particularly want to run a national programme as a Women's Health Ambassador and Sue at NHS England, based on this is cost-effective, I'm conscious of the fact that in the political environment in which we live currently, that if it's going to cost a lot of money, it's not going to happen. And I believe that by organising our services differently, we're going to be able to save significant resources in health and put them into the things that are going to happen right at the end of that graph, after the menopause and in those years when most of the women are going to die of heart disease, the complications of osteoporosis and frailty and immobility, and also dementia. So you probably thought we were going to start talking about things like endometriosis and polycystic ovarian syndrome and the new types of ovarian cancer diagnostics. But I'd just like to remind you all that nobody wakes up one day with endometriosis or polycystic ovary syndrome or with a cancer. These things develop over time. And what we've got to do, I think, is get in right at the beginning and find a way to get women the services that they need. So along the backdrop, and before I ask you for questions and thoughts that you would like to share, just remember what our government's 3 missions are at the moment. They are to move from analogue to digital, to move from hospital to community, or intermediate care, as I would put it, and to move from treating sickness into preventing it. And that always will be a cheaper option for us. And if you look at the McKinsey report, the Deloitte report, and then the NHS Confederation report, all published earlier this year, you will see that if we close the women's health or the gender health gap, we would save globally $1 trillion annually. And they've very, very helpfully at McKinsey done the analysis as well for just the UK, with our population of 64 million. And that would be a saving of $36 billion every year. And I'm reliably informed that that is 20% of the whole of the NHS budget that we could save if we close the gender health gap in the UK. So over to you. We've got to go from analogue to digital, hospital to community, and from sickness to prevention. How are we going to do it? Will you hand them a microphone? Thank you. And please tell us your name and what you do, and then if you want to address it to a particular member.
Okay. Hi, my name is Amaya. I'm affiliated with Barts. I do research there, but I'm from America, if you could tell. So I'm actually going to be talking from that perspective. So I've been both a patient and a healthcare worker in America, so I kind of have like those perspectives. And one thing that I have noticed is a similarity between the UK and the US in terms of a solution, but also an issue, is the electronic health record system, which Dr. Yogi touched upon, which I think would be a really good source to optimize and improve via AI and technology. So what we use to schedule, what we use to record data. Perhaps we could optimize scheduling to include like functions that account for a person's medical history when you're scheduling an appointment, or perhaps you can use AI to based on the symptoms entered in an EHR to predict or to come up with predictors for how severe menopause for a certain individual it could be. There's a lot of potential there when it comes to creating solutions to optimize an individual's experience in a physician or with a physician via an electronic health record system.
So can I just interrupt a second? Can you encapsulate your question?
Yes, sorry. Yes, and so my question is that one of the biggest issues, I think, which was also touched upon, is that people don't tend to bring up symptoms at appointments, especially women, because they don't know what to look for or they don't know what to think about. Someone touched upon earlier about the idea of non-specific symptoms being a predictor of so many women's health issues. So what are your thoughts on how we can specifically encourage women to always think about women's health in the current landscape? But not just right before their appointment or in their appointment, but when they're not going to see a doctor for the next few months. How can we encourage women to constantly think about their own health and their own women's health and what symptoms they should be looking for?
Sue?
A really, really good question. And I think some of it is about language, because I think that, it's about the medical community meeting the kind of citizen community in a way. And I think we need to get better at talking the language of symptoms, because I think that, as Leslie was referring to earlier, people don't start with endometriosis. They start with probably painful periods, and we can all understand what a painful period means. I just think that we need to get better at not labeling it as this or that, but speaking the same language. I also think the point that you raise about the electronic record, it needs to track from those symptoms through to diagnoses if indeed they emerge. So, people present with a symptom, they may or may not end up with a diagnosis. They've still got a symptom, even if with painful periods as an example, they may still have painful periods. We might not find an underlying disease cause. We would, of course, look for it, but they still need treatment and they still need care. So I think it all boils back to thinking about symptoms and then the data linkage right through the pathway of care so that we can understand how these symptoms predict or don't predict or shape the development of disease.
Thank you. Hilary, did you want to add something?
Thank you very much. I think you raised such an important point, and we've mentioned painful periods. You'll forgive me if I speak about heavy periods. And of course, immediately you have something that is stigmatized, taboo. People don't talk about periods. Girls in school, perhaps now across the generations with the use of apps, etc., there is a widening of awareness. So what we need information that is accurate, and that whatever site or source you use is the same, and it's not mixed messages. Because once you begin to stop normalizing a symptom, whether it's pain or whether it's amount of heaviness of a period, you begin to realize that perhaps you have a symptom that you have been ignoring and that you shouldn't be ignoring and that you should potentially seek some help for, because it may identify, as a result of that symptom, a condition that if it was recognized earlier, there could be earlier intervention. Or it may just flag that perhaps for years your periods have been really heavy, you felt exhausted for years, but nobody's thought to think, well, my periods are heavy, I could be anemic, and I could be iron deficient, and if we manage that iron deficiency, we manage that anemia, we feel better, and that if we're going to then maybe have a pregnancy later, we may actually have a better outcome of our pregnancy. But it's about how do we record when somebody needs to seek care, and is that information available when you access another part of the health service, so that you don't have to have repeated tests, or there's an alert that when you see some other aspect of healthcare, it needs to be recognised. So sorry to give a long comment, but I think what you raise, and maybe the electronic record can help us, but we also need information that is reliable and that is correct and that is consistent.
Shira, do you want to add to that?
Very briefly. Thank you. Great question. So, as a clinician, clinical decision support tools are helpful. We use them all the time. It's a translation of, say, NICE guidance into templates that will prompt me as a GP to remember to ask the right questions or to prescribe. However, as a GP, I also find that human interaction, AI is valuable, but it doesn't replace that connection that you have with a patient. Because women or men or patients will not necessarily tell you what's really happening. Sometimes they suss you out and they come with a sore throat, but what they really want to talk about is something else altogether. So whilst technology and AI are incredibly helpful and valuable, we need to make sure that there is also the space for that connection.
Thank you.
Secondly, in terms of who is designing these AI products and tools, we need to make sure that the product developers, the people designing strategy and implementing it are representative of our population. At the moment, I think we still have a long way to go, and therefore we need to make sure we champion inclusion in how these products are developed and implemented to make sure that they meet the needs of our population.
So the lady sitting next to you had a question.
Hi.
Make it brief, please.
Hello, everyone. I am actually a protege as well. I'm also an Imperial College student back in the days. I'm a mother of 6, so in terms of these issues, I know that many of them will hit me. I am presenting a solution of sorts in terms of moving from analog to digital, moving from hospital to community, and also being able to empower families. So I lead at the moment a parent education program whereby we have a multicultural clinicians from GPs, pediatricians, nurses, health visitors, support and teach parents. We kind of draw them in through teaching first aid, but use that as a platform to address all sorts of health conditions, especially geared up to improving their health for children. But through that, we're empowering them. They bring together, and that power of peer support, such that we're delivering sessions in other languages, so Polish, Arabic, Turkish, using tech by connecting everyone through simple things like WhatsApp groups. We've got I come from North London, and the area that I work and live in has high levels of deprivation. So those personal connections, like you spoke about, Dr. Chuck, are really important. People don't want to just trust their apps. They need to be introduced to them, and being able to relay the problems that they're having with hospitals by coming under an acute trust. It means that we've built up that trust, that we're able to advocate for those families. So I'd love to see more support to do fairly simple things. It doesn't cost that much at all in terms of what we're trying to deliver. And
So you're saying that we need to have much better educational tools, aren't you, so that we can raise awareness and ensure that the information is bona fide. And I wonder, Sue, if you want to come in at this point and talk a little bit about the group sessions that you've been running in your neck of the woods for menopause, which could be adapted to so many other aspects of women's health.
Yeah, thanks, Leslie. And I think it actually links really well with your question, because I really like the idea of hooks to bring people in. So people only show up to things, don't they, if they've got something to gain from it. And if we run these groups, so we invite people through their GP practices. Difficult in terms of platforms, that's a whole nother question that needs answering, but we invite people proactively who we think might be interested. So we invite them for menopause, we invite all women over 45 for an education event, and then we run group consultations online. They are so popular. We fill up our slots, 200, 300 women, very, very quickly. We ran a similar one for contraception, and hardly anyone came. And I think it speaks to your point about what are the things that people want, what will they show up to, and then what else can you help them to get that they might not have recognised that is a need that they maybe haven't been exposed to. So I think it's a really well-made point, and I'd like to put a question out of how tech can support us to be proactive out to the community, bring people in for information and support, and then bring them in further to the to healthcare if they need. So people themselves can self-select, and I think that sort of relates a bit to what you were saying, Hilary, about, you know, recognising normal and not normal. All the time in practice, I don't know about everybody here, but people say, I didn't know whether to come because I didn't know if it was normal or not. And then they'll say, every month I take a week off work because my period is so bad. And I have to say, that is not normal. But talking about normal and not normal is not appropriate. Helping to recognise when someone needs to seek help is important. So going out to people, I think, is helpful.
Any other questions just as we finish? Yes, the lady in the back, over there. You have to be quick because we've only got a few more minutes. I'm interested that none of you have pointed out to me that although we focused on these three areas, menstruation, contraception and menopause, that is very, very rarely part of an interprofessional conversation with a healthcare professional unless you're going to see a gynecologist. So why is it that the orthopedic surgeon doesn't say to me, so Leslie, have you stopped having periods now? I mean, he'd be pretty right about that. Yes, yes. Any problems with your menopause? You know, he doesn't need to know about that necessarily, but he does need to make sure that, for example, girls sitting on orthopedic wards who've just had a trauma case have enormous problems managing their menstrual periods, and nobody ever asks them about it. And it's just such a common occurrence that it's madness we do. I think you've got your microphone now.
Yeah,
Over to you.
I've got my mic. My name's Lauren, and I lead the Women's Health Research Team at West Middlesex Hospital, midwife by background. With these women's health hubs that are coming, do we feel that there's potential for women's health research teams to be embedded in the community?
Very much so.
Amazing, because we're not as accessible in the hospital, and we help our clinicians run their clinics. We can actually make their clinics shorter by us having a list so they can see more women when we're arranging the research for them. So that could help in community as well.
Very much indeed. And if you were to invite us back next year, I hope that Sue Mann and I will be telling you about the upscaling of the women's health hubs and how they are really catching on. Every single week when I'm talking about health hubs, another type of healthcare professional will come up to me and say, how can we contribute to this? So although we've been focusing this morning on the reproductive things and the post-reproductive issues of women, that's just the starting point. And I think that there'll be so many other fields that will want to include it. And it's an obvious place to ensure that research also goes out, and very inclusive research. So one of the other problems that you will be aware of is how women have been excluded from research trials and for drug treatment trials. And one of the ways we can do this is to ensure that the hubs are inclusive and that all those women are recruited in the future. I think I'm being told that we have to stop in a moment. That lady over there had her hand up. Do you want to ask a quick question and then we'll finish?
I think I can be audible enough. My question is regarding contraception and menopause. Maybe specifically comes to you. My name is Caroline. I'm a student of public health, University of Sunderland, London. My question is, what are we doing, especially at the GP level, to do evidence-based advocacy now that we are already speaking?
Thank you, Caroline from University of Sunderland, London, Public Health. What are we doing, especially in line with advocacy, since we already have the evidence? I'm happy to hear that you're already saying 600 women are waiting to meet doctors on contraception. And it's quite worrying. What have we done as the GPs in this country for evidence-based advocacy, especially utilizing all forums like university students? Because after here, I represent public health and nursing. I would like to actually meet so that we have a conference regarding this, so that we raise a voice together for the issues of policy advocacy. Thank you.
No, I can need to correct you. It's 600,000 women on the gynecological waiting list. They're not all there for contraception. But what we're saying is that women who require contraception, who require help with their periods, who need cervical screening, who need menopause care, they shouldn't be going to a hospital in the first instance. They should be able to be catered for in the community closer to home. And on that note, will you thank the panel members with me? And I hope the rest of your day goes well.